So we're now streaming live on YouTube, Mike.
Yeah, it's just preparing to live stream now, setting up your webinar for YouTube Live. It says it's done. That's
we're now streaming live on YouTube, Mike.
It is? Yeah, it's just preparing to live stream now, setting up your webinar for YouTube Live.
So we're just waiting a couple of minutes till 8, then we'll start.
There's a fair few watching, I think, on YouTube, so that's good.
So, Trisha and Ran, are you both pre or post exam?
I'm pre and Ran's post.
Okay, brilliant. Okay. So, Ran, you'll be the most freshest of all of us for knowledge.
It's been a while. it's been a few months. Unfortunately, the knowledge.
Any break of collectors questions, see what I can direct to you, yeah?
I didn't sign up for this, did I?
I'm sure you'll lose signal very rapidly.
Yeah, oh, I think it's going now.
Hi, Ran. Hi, I'm Mike.
Hi, Mike.
Well, we've got 29 attendees.
Yeah, I think there's 400 registered.
Right, okay, that will be interesting. Let's see. Are you hearing any background noise from here?
No, it's okay at the moment.
Okay.
So I guess training's been seriously disrupted, Trisha and Ran, has it? And
yeah,
it's just going to take a pause for 6 months or a year or so.
Yeah, I think it's going to be quite some time before we get back up to where we were pre-COVID.
And the current exam, how long have they delayed it for?
So the plan is, so the November sitting is the plan is to go ahead with that, but just have to work with things like social distancing and a different venue to accommodate it.
Yeah.
Yeah, so November's the plan.
It's difficult to plan your revision when there's no certainty, or you think it may shift because it must be a lot of your time.
It'll be hard for a lot of people who've got had courses booked. And obviously, the courses are invaluable before exam, so I think that'll be difficult.
And we run our course 3 times a year, but we've obviously stopped it because of the current climate, which is also why Mike wanted to start this up, which is a great idea.
Definitely.
Because we do fellow teaching already, but this just opens it up to a bigger field, and it should work quite well.
Yeah.
Yeah.
Right, attendees have just joined, 44.
We're almost 8 o'clock, Mike. Are you gonna?
Yeah, absolutely. I'm just sending you all a message now. These people are like busy people, you know, they're juggling lots of things. So they've got 1 more minute of their free time. Might be just watering that last rhododendron bush, you never know. At 8 o'clock, it'll just suddenly, all the participants now are all absolutely clicking in now. So what we'll do is we'll just start once it gets to 8 o'clock, and then people will join in. As I say, we'll start with me because I'm the least important person here speaking.
Headline.
What's that?
Headline act.
No chop, no problem. Right, so it's 8 o'clock, so we'll get started and sort of welcome everybody. And we're going to be recording this, so it's only really to the panelists. So if all the panelists are okay for this to be recorded, it just means it's available. I've had messages all day today from trainees and from docs saying, can we record it and put it on YouTube so they can watch it when they're not on call? So if you've no objections, I'll just start recording this now to the cloud. And we'll just go to a screen share now. Well, welcome everybody to the first in a series of Sunday Supper with Wrightington, aimed predominantly for FRCS revision. But of course, there'll be lots of other people will be taking advantages of these kind of online resources, therapists, nurses, staff grade clinicians, consultants, medical students. So it's open to absolutely everyone, and it's a real privilege to do this in association with BOTA, and it's great to see Ram and Tricia here as panelists on behalf of BOTA. So welcome aboard and welcome to the Wrightington family. I hope this will be a successful venture together over the next few weeks, months and years. And it's an unusual time to choose Sunday night, but all our diaries are so packed. We just felt like this was a little bit more informal. 8 o'clock, most people are getting themselves settled, and maybe just 1 hour of just watching, relaxing, and taking in a bit of information may be of use to you all. So what we want to do is provide you some informal teaching from the comfort of your own home, and perhaps even the safety of your own home. Improve your knowledge base, and it's going to be interactive. So we're going to be doing some MCQs at the end. There's plenty of opportunity to do Q&A. So my other panelists can be fielding those, and I'll be fielding them when other people are speaking. But ultimately, we want to get you over the line. We want to get you through that exam. And there are certain things that we've picked up along the way. We only want to be doing sort of 3 15-minute lectures. That gives us a bit of time for MCQs and Q&As. We may even offer some live vivering if there's a couple of candidates who perhaps want to be vivaed in front of over 1,000 people. That would certainly replicate the stress levels of an exam. And of course, that person will have had psychological testing and support after such a session. But that might be a bit of fun, or we might even viva, one of our fellows at Wrightington, just to give them a little bit more of an experience. So this is very much a fluid structure, and this is the first in a large series of these lectures. Tonight we're focusing on hand and wrist. Next week we're doing elbows. So we've got Adam Watts, Matt Ricks, and Andy Wright going to be talking about elbows. The week after we're going to be talking about shoulder. Then we're going to look at basic science, and then we're going to go to lower limb for those people who are interested in lower limb. But hopefully we're going to be shaped by your email, so you can email us all. Let us know what you want to be taught. We have 2 eyes and 1 mouth for a reason, and that's we should be listening rather than talking. So please, can you tell us what you want? If we're getting it wrong, let us know. And that's how we have shaped the FRCS revision course at Wrightington over the last 25 years to be what you want it to be. And every year we make a few little tweaks in our format. So tonight, I'm going to be talking to you about base of thumb OA. It's very unlikely you'll get a patient in the exam as a clinical patient because they're quite sore, but it's often a really good part for the viva, just to talk about options for treating base of thumb OA. So that's kind of what I want to talk to you about from that point of view. So there's a few of you raising hands. Unfortunately, I'm in midstream and I'm a bloke, so I can only do one thing at a time. So what we'll do is send some Q&As, and some of my fellow colleagues and panelists might be able to answer those to you. Then the next speaker is going to be Matt Ricks, who's one of our newly appointed consultants at Wrightington, got real interest in trauma. And he's going to talk to you tonight about decision-making in distal radius fractures. You'll be really unlucky to get an acute distal radial fracture as a short case, but what you might get is a scenario about how you're going to manage this fracture. Remember, this exam is based at a level 1, day 1 consultant orthopedic surgeon. It's not based on a consultant of 20 years experience doing hand and wrist. So we will be presenting you in the exam with a fracture that could easily come to you as a day 1 consultant. So Matt's going to talk you through about decision making with that. And then CYNG is going to be talking to us about brachial plexus made easy. This was an absolute nightmare for me when I was doing the exam. I just could not get my head around it. I found it extremely difficult, and CY has now broken this down and speaks at our course every year, making it easy for you, and you'll be bowled over with his enthusiasm. He did promise he was buying a lectern, so he would be able to stand up and speak to you from a lectern. So I haven't seen any evidence of that, but certainly tune in about half an hour's time and see if we can deliver a lecture. So, right, so first technical glitch, my slides have, oh, there we go, have stopped, but we've gone on now. So next week, as I mentioned, we've got elbow, Adam Watts, Matt Ricks, and Andy Wright talking about elbow. So we'll start off with my talk. My charge now is base of thumb osteoarthritis. I'm a paid speaker for Striker, Med Artist, and Arthrex, but I'm not being paid for this talk, clearly, because this is for your interest. But I will be talking about some of their products, but I certainly will not be pushing any of their products on you. So what the patients with base of thumb present with, they present with well-localized base of thumb to the dorsal joint line. They also can have a deep aching in their thenar muscles, and their pain is made worse with load and rotation. And such things as turning a key in a door or using jam jars, those are the sorts of things that they might present to you. They'll also say that my thumb feels quite stiff, and they'll have this lump down at the base of their thumb. And we'll come on to why they've got a lump there. So with all examination, when you're in an exam, you know, you start to go into panic mode, and we can always go back to the aptly look, feel, move. So if you panic, you've got a white light in front of you, your brain is just completely evacuated. Just go back to those principles and it'll suddenly get you back on track. So just look, talk about what you see. So here I would be talking about, I can see that the base of thumb is somewhat squared off. I can see that they perhaps had a previous cortisone injection. There's a bit of bleaching there, lipodystrophy. And then also look to see whether they've got MP joint hyperextension. So that's what you'll be looking at on look. And then you go to feel. So the pain is really well localized to the joint line. And, you know, my great mentor and all of our great mentors, John Stanley, would always ask their patients in a hand clinic, point to where the problem is. If you had some fairy dust or some gold dust on the tip of your other index finger, where would you put that? And the patients will present really quite well localized to the base of thumb, which is different to what they present with the Quervain's tenosynovitis. That patient will tell you they've got pain up and down their thumb. So if they go straight to one spot, it's probably OA. If they kind of go up and down the line of the extensor tendon, it's probably going to be a de Quervain's tenosynovitis. We can feel axial load with circumduction, and then the reduction grind test. I'm going to just show you those briefly. I want you to assess the degree of MP joint hyperextension as well, because that can affect what you do surgically. And then, of course, you want to check a joint above and below. You want to check the wrist for range of movement. For the exam, I want you to ask the patient to radially and ulnar deviate. And when you all radially deviate, your scaphoid will flex forwards underneath the trapezium. So if they get increasing pain with radial deviation, you might want to think about whether they've got ST joint involvement as well as CMC joint involvement. And that's really sort of a gold medal answer. So if you can get that across, I'd just like to ask them to radially deviate, to flex their scaphoid forwards on the undersurface of the trapezium to see whether there's any coexisting ST involvement. That would be a really great thing to try and get across to the examiner. And so when you want to start moving them, the first thing you want to ask the patient, if you do get them as a short case, is your thumb sore? If it's been examined 2 or 3 times before you've got there, it might be too sore. So it'd be great if you said to them, is your thumb sore? And they say yes. You could then look to the examiner and to the patient to say, you know, the patient has said it's sore. Is it okay to proceed, or do you think we should just talk about it? That would be a really nice thing for you to get across. You want to ask them to do a Kapanji score, getting the thumb down to the base of their little finger, And then also ask them to hyperextend the thumb, and you could passively hyperextend the thumb to see if they've got this compensatory hyperextension. So why do patients get compensatory hyperextension at the thumb MP joint? Well, in this X-ray, you can see that the thumb metacarpal is now adducting and it's subluxing out. And if the thumb did not hyperextend at the MP joint, the tip of the thumb would start to miss the index finger. So their thumb would come across. So to compensate for that, what they do is they hyperextend so that their thumb can now touch the tip of their index finger. Special examinations, sometimes in clinic are not needed. I can make the diagnosis just looking, talking to them and getting radiographs, but occasionally we do need to perform some special exams. These are on YouTube as well. This is the axial grind test. So what you're trying to do here is just basically push the thumb metacarpal in line with the thumb and grind it against the underlying trapezium. And of course, as soon as the patient says to you or ow, or starts to tense as though they've got some discomfort, you should stop that test immediately and just say that's a positive test. Then there's the relocation grind test. Here's the shouldering that you can see. This is the thumb metacarpal adducting out. And what you're going to try and do here is gently relocate that back into the painful area and then circumduct. And again, that can be tender and you don't need to do it if it's clinically obvious. So you investigate these with plain radiographs. And what I would tell you to do is the take-home message for this is a lateral wrist X-ray in all base of thumb osteoarthritis, because you want to know whether they've got a DC deformity in the cases of coexisting ST arthritis. And if there is, by taking the trapezium out, you may actually cause their wrist to start to collapse. So that's the take-home message, is base of thumb osteoarthritis is AP lateral wrist, looking for the DC and perhaps a stretched out wide SL. And then you want to do this AP Robert view of the thumb CMC joint. And you can see that X-ray at the top showing it. And when you're looking there for the intermetacarpal osteophyte, you really want to know about that preoperatively because you'll go and hunt for that intraoperatively. But, you know, many of us use X-rays during the surgery as well, just to make sure we've got all of the osteophytes down. So this is this patient with coexisting ST osteoarthritis with thumb CMC arthritis. And you look at that MRI scan below. So you're going to proceed with caution with these. Ultrasound occasionally helps with injection localization, and occasionally patients will have had an MRI of a CT. So how do we manage these for the last couple of minutes? Well, we all know about Montgomery now, and you want to get that word across in your exam and explain what Montgomery is. Well, Montgomery is giving all the options available to the patient, and it has to be in terms that they understand. Being northern and not particularly bright, I can usually talk in words of just 1 or 2 syllables to try and get that message across. But you need to make them understand what the surgery is, what the risks and complications are, and what the natural history of this condition may be if they do nothing. And do nothing should always be an option for patients. So non-operatively, you can just say, well, it's osteoarthritis, can live with it. Our hand therapists are very useful for splinting. And that could either be a hard splint, a soft splint, which you can buy off the shelf, particularly in this COVID area. We're often sending out some of these off the shelf splints. Hand mobilization and muscle strengthening can also, has been shown to be advantageous in the early stages. Injections, we tend to do these under image guidance, but if you don't do them under image guidance, you can do this aspiration recoil sign. You'll put some local anesthetic into the joint, inject with the barrel, the patient will feel the joint expanding and will be sore. You take your thumb off the barrel, and if it backfills into the syringe, you are injecting into a closed space, such as a capsule. If you're injected into the muscles, the thenar eminence, you release your thumb, it won't recoil. And it's just the same as injecting into a tennis ball, release your thumb and it will backfill. Inject into a sponge, release your thumb, it won't backfill. So I really like to use the aspiration recoil sign. The majority of us use corticosteroid, whatever. I use Kenalog because it's soluble. And some people use hyaluronic acid and PRP. We're obviously in a COVID period, and there's been a paper by the rheumatologist suggesting about corticosteroid might make you at more risk of COVID and getting a worse form of COVID if you get it. But that literature is pretty ropey, and it's still under review at the moment. So the next few weeks or months will give us the answer whether we are safe to proceed with corticosteroid. But here's a paper that after 24 weeks, even if you give a cortisone injection, you're more or less back to where you were. So we can certainly say that patients benefit from corticosteroid in the short term. And I've got lots of my patients who really like their yearly injections. They don't want any surgery, and that's fine by me. The risk associated with it is damage in their articular cartilage, which is already damaged. So for surgery, you can do a neurectomy. I've got very little personal experience. There is some literature, but extremely small case series. When you want to explain this to patients in terms that they'll understand, you want to tell them, I want to stop the bare bone rubbing against each other, no matter what joint that might be. The hip, obviously a very simple bone, it's just got two, it's a very simple joint, it's just got two bones. You know, we're looking after 64 bones in the hand and wrist, and it does take that slightly more articulate and intelligent clinician too, but I'm not knocking the hip surgeons. Osteoarthritis is just wearing away of that smooth articular surface. So say to the patient, I want to stop the bare bone rubbing against each other. So I can do that by removing the surfaces, an excision arthroplasty. I can do that by fusing the surfaces together and stopping the movement, fusing the joint, or I can replace the surfaces. And so once you've given them that three simple principles, you can then build into that your specialist terminology about the various types of things. But I think in the exam, if you want to try and get across to the examiner, you know, that you're a patient advocate, you're able to talk comfortably to patients about pathology and about what's gone wrong, try and break things down into things that they understand. So my practice, 2018, if you're over 60, you've got a trapeziectomy, simple trapeziectomy. Under 50, you've got a thumb CMC fusion. And in the past, I've done obviously LRTIs, Wilby slings, and silastic trapeziums, which you can see there. But there's this 50 to 60-year-old age group that they might want to start to talk to you about in an exam. And so I think it depends how old you are. So there's some really big 59-year-olds who are acting like 35-year-olds because they're doing heavy weights every day. And there's some really frail 50-year-olds who are acting like a 71-year-old. So it's not necessarily about the age, it's physiologically how old they are. So this is what I do, and this is I'm averaging at the moment. Again, over 60, you're getting a trapeziectomy. I do 20 a year. I do a few hemitrapeziectomies. I do CMC fusions for that younger person. I do about 17 of those a year. And we've started to do thumb joint replacements. And that's come on over the last 2 to 3 years. And we'll just touch on that because there are some papers coming out suggesting long-term results are very, very favorable. So any surgery, my old boss in Liverpool used to say to me, you only do a joint surgery for pain and misery. So ask the patient, are you in pain and misery? And if they are, you can offer them this type of surgery. But if they're not at the pain and misery scale, they might just want to have something more conservative. We want to prevent the bone rubbing, reduce pain, and maintain function. So what I want you to get across in the exam is the risks particular to base of thumb OA surgery. So all thumb surgery has a risk of a neuroma, and this is one that was occurred from a de Quervain's release, but it shows you what a neuroma kind of looks like. You can see why there. He's looking at his lips, looking at that, thinking there's lots I could do with that. For trapeziectomy, you've got proximal migration, and then for thumb CMC joint, you've got non-union. So those are your sort of main risks associated with those. Trapeziectomy, I perform this, what's called the modified Wagner approach. It doesn't really matter how it does. I think in the exam, you should say you do it under X-ray control because you don't want to do this. You don't want to remove the trapezium and the scaphoid. I do a cruciate osteotomy, and I take out the trapezium in pieces. I then check it with my finger or on X-ray to make sure I've got rid of that intermetacarpal osteophyte. I do the little finger sweep inside to make sure I've got all the bones. And then when I'm closing the capsule, I put my knots deep inside, so it prevents risk of them irritating the superficial radial nerve, which may cause either a neuroma or a CRPS. The upside for trapeziectomy, it's the commonest operation we do. It's very quick. Randomized control trials from Tim Davis in Nottingham suggest you don't need to sling them. You don't need to do an LRTI. Just a simple trapeziectomy will do. It's super cheap, no dislocation, no wear, and no fracture. So that is the main go-to operation for the majority of hand surgeons. The downside is there's a fair bit of recovery. It's not a quick operation to recover from. And this is the big one that we worry about, is proximal migration. So the metacarpal grinding down into the trapezium. And that is a disaster if that occurs, and it's symptomatic. It's very, very difficult to deal with. So I just want to mention that again. Look on a lateral radiograph to make sure they haven't got a DC deformity preoperatively. Check the thumb for hyperextension, because you may need to address that either with a thumb MP fusion or a volar plate tightening of the MP joint. So CMC fusion, very similar dorsal approach, incise the capsule, and then I do reciprocal V-cuts with high flow saline to keep the temperature down to reduce thermal necrosis. I do K-wire holes on either side, and you want to try and get good coaptation. So you want to get accurate cuts. Here's a V, and then I tend to hold it with some staples. I avoid K-wires. There's a very high non-union rate. We published that a few years ago. I avoid plates because there's long incisions. You don't really get much compression there. I avoid screws because the screw going from the metacarpal towards across can impinge against the trapezio-trapezoidal joint. Can you see that's got a little tiny facet there? So I avoid screws, and I've gone to staples now. And these are the staples that I use. 15 by 12 for a large hand, that's a male, 13 by 10 for a small hand. There are a lot of advantages to these. You can adjust the legs, memory metal, so you don't need to freeze them or heat them. And there's some nice slots to guide them into the soft tissues without losing the hole. So the fusion upside is it's simple. It's quicker recovery than a trapeziectomy. Once they've fused, they're good to go. Very strong, durable, will hopefully last them their lifetime. And with internal fixation, we're getting good union rates. The problem for these patients is their thumb can't lie flat. So their thumb will kind of be hanging down, and they can't get their hand flat on a table. And provided you tell them that beforehand, they're usually accommodating with that. If you don't tell them that, some patients kind of don't really like that. So you want to tell them inability to contour the hand flat against the table. So, and then some CMC joint implant, I've put a lot of sielastics in many years ago. They work really well if they stayed in, but quite a few of them subluxed early. And now we're starting to put a two-piece component. There's a number of these on the market. I've done 12 in the last 20 months, and they all seem to be doing very, very well. To do this, you want to make sure the metacarpal base is fully released, use a lot of x-ray, and with any of these joints, don't overstuff the joints. Colleague in France is doing these under wider weight local anesthesia surgery. He's done over 50, so we can get the tension really, really nice. Upside is it restores anatomy, quicker return to function. Here's a patient that's done pretty well at 6 weeks.
6 weeks.
No pain.
Post in CMC, just move your thumb around for me. Any pain?
And so, you know, she's going to have a Kapanji.
Little finger, walk it down your little finger, all the way down to the base.
She's done great. And that's at 6 weeks. So we think that they get a quicker return to function. Recent literature that's about to come out, this paper, 10-year data showing excellent survival rate. The upside is it works, but is it better? And we need that randomized controlled trial that hopefully we're going to be doing in the next few years. The downside is there's cost. Someone's got to pay for the implant when you don't for trapeziectomy. Operative time's longer, and you know it's a bigger surgery. So implant failure, what happens now? You would probably just do a simple trapeziectomy, take the implant out. So in summary, there's lots of options for base of thumb. So hopefully I've covered those 3 main areas for you. You know, get across that surgery is always a last resort. And when you're starting to do arthroplasty, fusion, trapeziectomy, they've got to really need it. So it's for pain and misery. So hopefully you'll have enjoyed that. So I'm going to now stop screen sharing. And I'm now going to invite Matt. Is that okay, Matt? So you okay?
Yeah, all ready to go. You just need to activate screen sharing, Mike.
Panelists. Right. How do I do that? This is going to be really awkward if I can't do that. Panelist, Matt. Stop video. I'm going to make you a host. Okay. You should be able to do that now, Matt.
Yep, good to go. Lovely. Can you see that?
Yep.
Yeah.
Brilliant. Thanks. So thanks, Mike, for the invite to come and go through distal radius fractures. So I've got 15 minutes to cover quite a big subject. Key thing I'm going to focus on is what they're going to ask you during the FRCS and a basic level of knowledge that you can have whilst answering questions with the FRCS as well. So distal radius fractures, they're common. 20% of all fractures in adults. There's a bimodal distribution to the fracture pattern. You have the young patients who tend to be quite high energy and therefore have quite complex fractures with a high association of soft tissue injuries. Then your elderly patients who tend to be low energy, but because of their osteoporotic bone and bone complex, they tend to have quite nasty injuries, even though it's low energy as well. So it's key to identify these when you see the fracture patterns. There's intra-articular in 50%, and you need to be aware of the associated injuries with wrist fractures as well. This is absolutely key because there's a 70% association of soft tissue injuries, which range from the TFCC tears to scapholunate ligament injuries to lunotriquetral ligament injuries. So it's vital that you identify them, or at least look for them or highlight to the examiner that you're aware of the association of injuries with distal radius fractures. We know the distal radius makes up for 80% of the load. It articulates with the scaphoid via the scaphoid fossa and the lunate via the lunate fossa, and the distal ulna articulates via the sigmoid notch. We know the column theories as well. You need to know the column theories when you're looking at distal radius fractures. We know about the radial column, the intermediate column, and the ulnar column as well. We know about the radial column articulating the radial styloid and the scaphoid fossa, and how it serves as a buttress to resist radial carpal translation as load-bearing platform for activities with the wrist in ulnar deviation. We know that the intermediate column includes the lunate fossa, and it functions and transmits loads from the carpus to the forearm as well, and how the ulnar column is important, particularly with the ligament and stability of the TFCC and the distal ulna. You know, the FRCS nowadays aren't allowed to ask you specifically for classifications, but it is important you know common classifications and how to apply them as an orthopedic surgeon, whether it's articulating the fracture pattern you have to a colleague or the understanding of a fracture pattern. And that's what the FRCS is. It's understanding that you know what the fracture pattern is and how to manage it. You'll know about the angles and heights, the distal radius, about the rules of 11 and the volar tilt of 0 to 11 degrees and the radial inclination of 22 degrees, because these are the factors you're looking for on an X-ray if you're shown it in the FRCS examination. So what are they testing? They're testing your knowledge. Hopefully in the vivas, you've already demonstrated that by passing the written, and they want to know that you have a methodical approach to answering the question. And that's key because it shows that you have a methodical approach to managing patients. And that's what this all is about that you will be a safe consultant managing your patients and that you know your limitations. Because there will be times where you have cases that are outside your skill set and you need to identify this and refer it on. And that makes you a safe consultant and will allow you to pass the FRCS. When you see an X-ray like this in the FRCS, you'll think, brilliant, winner, it's an easy one, it's a Colles, I'll plate it, next question. Now that's not the answer. It is a simple fracture, yes, but it's a great opportunity for you to shine. It's your time to shine. So it's a dorsally angular distal radius fracture, it's extra-articular, and the factor you have to know is that, why are they asking me this question? They're asking it deliberately to allow you to demonstrate your knowledge, to show your methodical approach, and allow you to get literature in there. So you can score the 7 and 8s, the highest scores when it comes to distal radius fractures. So they will show you this X-ray in the back of your head. You want to know, right, this is my chance, smile, big breath in, and then give your answer. And you can bring literature into it. So you highlight the fracture, extra-articular distal radius fracture, how it's dorsally angulated, how you're going to liaise with the patient, go through the risk profiles, and weigh up multiple factors. And then you will base your decision based upon evidence with an in-depth discussion with the patient. As Mike said, the Montgomery ruling is key nowadays, and the patients have to be properly informed. So your current evidence that you can mention is the draft trial. So you've got draft 1, draft 2 being done, but draft 1's a great one to mention during the exam. I'm not going to flood you with papers, but I'll highlight a couple of key ones. So when you get x-rays like that, you can smile, big breath in, and then impress them with your knowledge. So the crux of the paper, or all that a hip surgeon needs to know, is it's a multi-center RCT. It was for dorsally angulated fractures, and it had showed no difference in outcome between K-wires and locking plates. So that's for your hip surgeon. To your hand surgeon, if you just said that, they get very angry. So there's a lot of pros and cons to the paper, and you could spend hours arguing it or negotiating finer points. But for this, that's enough. It shows why you're doing your options you're doing and gives you the evidence to get onto your 7s and your 8s scoring for your FRCS. So the great thing, there's lots of guidelines. There's also a guidelines on distal radius fractures from BOST. So this is a great one to quote when you're shown distal radius fractures during the exam. It shows that you can do casting, that you do three-point molding, which I would do a question, but written by Charnley in his book, which none of you have, you should buy. It's a great one. And it talks about the length of time you immobilize them, x-rays after, but it also brings a great point, these new guidelines, on the over 65 and considering conservative management for dorsally tilted fractures. So if you're shown that colleagues, and they tell you is 85 years of age, lots of medical issues, they may be seeing, if you're aware of the literature, that there are situations where you can conservatively manage these patients and leave them alone. And there is. And this would be a great paper to quote during it, and you highlight the BOST guidelines for it. So that's a simple fracture, hopefully scoring 7 and 8s. But what about a complex fracture? What about when they show you something nasty? A distal radius fracture like this. So whenever you see fractures like this, you always think first, why are they showing it to me? Now they're showing it to you because it's complex, because it's nasty. There's multiple elements here that could catch you out. So looking at it, you can tell it's comminuted, it's intra-articular. Obviously there's fragmentation dorsally, and it's a nasty fracture. You won't have a CT to look through, but the CT will show you and reinforce it's a nasty fracture. And the reason it's nasty, the reason you're getting those x-rays is because there may be certain options that are on the boundaries of their management. So if you suggest a volar plate, which in majority or some fractures is a very good option, good fixation, but the concern is that dorsal comminution. You know, there's fragments all at the tip, and if you look at the carpus as well, there's a lot of weight going dorsally. So my concern is you won't be able to hold it. And in this situation, it wasn't. And so you weren't able to maintain the integrity of the wrist. It slipped off, and it needed another plating from a dorsal approach. But if you identify from the fracture, if you know that it's nasty, it's complex, and you highlight this to the examiner, it's a complex intra-articular fracture. There's dorsal comminution. These are factors that make me think it's going to be a hard fracture to maintain reduction. Therefore, I may have to consider a dorsal approach. Now, if you mention a dorsal approach to an examiner, their next question is, draw me the extensor compartments of the wrist, or talk through the dorsal approach to the wrist. So this should be a given. You should be able to draw a picture. You should be able to highlight the ligament, the tendons inside each of the compartments, and then choose and talk through a common dorsal approach to the wrist. So the workhorse is between 3 and 4. So people elevate out EPL, and that gives you a beautiful approach to the dorsal portion of the wrist for fixation, for buttressing, for fragment-specific plating. But you know that if you mention dorsal, their next question is about the dorsal approach. So it's important you know that. Now, other fractures they may show you, like this, are chosen deliberately to see that you know that there are things associated with these fractures. So we've already highlighted the element of soft tissue injuries. This one has a high risk of moving and losing position. Now, if you argue to conservatively manage it in a cast above elbow for supination, that is an option. But if you do that, you need to follow it up like a hawk, because there's a high chance of these moving. And I know a majority of my colleagues who do a volar plate for these to fix it back down, to get the buttress there, to get the stability and early mobilization. But the key factor is you're shown this x-ray, you know they're showing you for a reason, and you identify that. And so you're able to understand and have higher level thinking. So what about if it's a really, really nasty distal radius, like this one? So again, you look at the x-rays, you think, whoa, that's horrible. And you think, why are they showing me that? They're showing you it so they can test that you have a methodical approach and you're a safe consultant. And that's key, because this is a nasty fracture in anyone's hands, even if you've got the experience Mike has with these. This is nasty. And if you look at the x-rays, I would comment, this is a complex distal radius with a significant comminution to the articular surface. In fact, it looks like dust, and I'd be very concerned about trying to keep the reduction and holding it in position. There's lots of options for this fracture. You know, you could mention K-wires, volar plating, X-fixes, dorsal plates. But if you mention K-wires or volar plates in this type of fracture to an examiner, and if they're a hand surgeon, then there may be some difficult questions that follow, because I think this would be very difficult to maintain reduction with K-wires or a volar plate, mainly because of the degree of comminution to that articular surface in the fragments. There's going to be a high energy injury to the soft tissues. You also need to comment on whether it's open, neurovascular status as well, and the degree of soft tissue injury, because all these factors come in to your decision making when it comes through to it. So I would highlight the complexity of this fracture, that K-wires or volar plates may not be suitable in this fracture pattern, and I may have to use a bridging method. This is either an external fixator, which if you're a non-hand surgeon, you'll be expected to put on, or if you're a hand surgeon, you could be considering putting on a bridging plate. But it is a nasty fracture. This is what we did, and we did a bridging plate across it after a colleague had done an X-fix they sent to us. But the key factor is they appreciated the comminuted nature of it. They didn't try and plate it. They didn't try and K-wire it. It is nasty, and then they referred it on. But it's a big injury to have, and it's something you need to recognize as an orthopedic consultant, because it's key. It makes you safe, and it makes you mean that your patients have the best operations by the right people in the right place. Now, open fractures is common with wrist fractures, and so it's key that if they show you a picture like this, that there's going to be a trail or a leading questions that will follow it. So you need to be able to identify this, think, why are they asking me this question? So in the presence of open fractures, there are guidelines. Now, we've already mentioned the guidelines on distal radius fractures, and it says in the position of open fractures refer to our other guidelines, which are these ones. And coming up to the FRCS, you should be able to quote all of these, because this could come out in multiple different points, whether it's wrist, open tibia, and it has exactly the same factors that you need to implement to maintain the high level of care to your patients and get the best outcome. And it, you know, most of it's common sense. So antibiotics, good idea. Yeah, open fracture, give it quickly. So now it's 1 hour. Used to be longer back in the day, but they've changed it. And you have to assess compartment syndrome, neurovascular status. And the reason that is because it usually our open fractures are high energy, and so therefore there's an associated soft tissue injury with it. But as we mentioned before, there's a spectrum of injuries with your bimodal distribution of distal radius fractures. So you may have your shattered distal radius, so your high energy who came off a motorbike, who's got a large chunk of soft tissue that's missing. That is different to an elderly patient who has an abrasion over the volar aspect of the wrist, which has breached the dermal layer. So there are differences to the open fracture nature. When you're talking about open fractures, you need to be able to talk about your Gastillo-Anderson classification, which is done after the initial debridement. And these are leading questions. So if the examiner shows you an open wrist, you talk about this and lead you on. And then you're in the higher levels of 7 and 8s for the discussion of your cases, which will hopefully allow you to give a better scoring for the FRCS. If you're asked simple fractures, it's a gift. It's giving you an opportunity to show the evidence that you have, the methodical approach that you have, and that you're a safe consultant. If you're shown the complex ones, then you need to identify why it's complex, because that's key, because it shows that you understand the fracture, that you appreciate the nature of it and the complexity, because these type of fractures, not everyone will be able to manage. And so therefore it's key that you identify they're complex and identify that you need to manage them in a certain way. And this means you'll demonstrate your knowledge, you'll demonstrate your methodical approach to answering the question, because if they think you answer it properly, they'll think that you manage the patients that way. And that's key, because at the end of the day, it's all about the patients, and it's about having a safe consultant, because as Mike said, it's the day one consultant they want. And you may be a hip surgeon, you may be the next budding hand surgeon, but you have to know your limitations and be safe. That's what it's all about. So hopefully you'll be able to identify that from risk fractures from that quick 15 minutes. Thanks, Mike.
That's great, Matt. That was an excellent talk. And so what I suggest now is I think you've got to make CY host now, and then he can then screen share. We're going to be ironing out all these kind of little things over the next few weeks. It's all quite a learning curve for us, but that was great. And so when CY is talking, Matt, you'll be getting some questions sent through to you about your great talk. So if you could just sort of field those to people, that would be great. So CY, are you okay to? Well done.
Right, ready? So we're going to change the focus now to brachial plexus. You can't be a concert pianist just by attending concert. I think that's a truism, and you can. So the point being that it's all very great. Now you have opportunity to look at all these examinations, the demonstrations. But at the end, you actually have to apply and practice. And better still, if you have a mentor, then your learning curve can be overcome more easily. The objective of this short talk is to give you some framework so that you can develop a practical approach to examining a patient with possible brachial plexus injury. And hopefully, you can also pick up a few tips when you are given a patient with possible peripheral nerve injury. Now, if you look at the ISCP, your syllabus, examination is given the highest weightage. You know, you have to know specifically and broadly, however you interpret that. And if you look at that, neurophysiology and reconstructive surgery, you need to know generally. The main bulk of this talk is about clinical examination. And I think also for your future practice, clinical examination is the key. So why is brachial plexus injury so daunting? As orthopedic surgeon, we can deal with three-dimensional objects. But when you're given 4 dimensions, i.e. the depth, the length, the time, and the breadth, it can be a bit more overwhelming. But if you take a step back and you appreciate when you are dealing with brachial plexus injury, there are actually 4 dimensions of the injury itself. You can begin, and that will be your first step to appreciating the complexity of the injury. And you can demonstrate that. You can demonstrate higher order thinking is an educational's list favorites. And now how can you demonstrate that? Hopefully I can give you some example later on to demonstrate that you are a hot trainee. What are the main clinical patterns that you are likely to encounter? So in the UK, in civilian practice, you are likely to face close traction injury to the brachial plexus. Now, if you get a motorcycle accident, the victim is likely to present with injury above the clavicle. And if it's above the clavicle, it's either going to be complete brachial plexus palsy or partial. Now, if you have a shoulder dislocation, you have a shoulder fracture dislocation, then it's likely that the injury is below the clavicle, in which case you discuss it in terms of cords or terminal branches. So get that, that's a key, get that in your mind about the likelihood where the lesion is going to be. Now, we have to be practical. Just think about if you are in the exam situation, what cases are you likely to encounter? You're not going to get someone who has come off the road traffic accident with acute brachial plexus palsy. You're not going to be given babies 2 or 3 months with obstetric brachial plexus palsy. But you might get neglected cases, and there are plenty of axillary nerve palsy after shoulder trauma. You may be given adults who had suffered with the injury for some years and who have gone on to undergo some reconstructive surgery. You can get children who are now adults who have had some surgery. But the important thing is your approach, and better still, your logical thinking. What should you be thinking of when you are examining a patient? It's not so much of what is the next step required. That is the beginners. But when you have mastered the steps, then the examination actually serves the purpose to inform you what functions are lost, what functions are present, and then from there you work out where the lesion is, and as a reconstructive surgeon, what can you offer to improve the overall function? I think for FRCS level, if you can reach this level, where is the lesion, you have demonstrated that you are a hot trainee. I know it's incredibly hot today. I hope you all have enjoyed your sunshine, but you get the drill. Is how to show that you are hot. Now, this is available on YouTube. I would not show the whole clip. You can search for it, brachial plexus exam CY, and it's meant to show you the routine of the examination. But brachial plexus examination is all about pattern recognition. Look at this patient. Before you even approach that patient, like you even lay your hands on the patient, just take a step back. Look at that left flail, lifeless, atrophic limb. Now, this is going to be a global injury. And what is this? This is a chronic total brachial plexus palsy. And you already know what the likely condition is going to be. Then you can slowly unravel the case, and then you have to go with what the examiner wants you to do. Do not insist on doing certain routine that you want, because there may be certain components. The examiner may just want you to look at the hand, and then you just discuss the hand as been requested, because the first pitfall is not answer the question that the examiner asks you to. So listen to the question and try to answer the question directly. So what is the first pattern? The first pattern is poor shoulder, poor hand, and it's a form of total brachial plexus injury. So let me give you one example. This clip is available in VuMedi. If you search for my name, you'll be able to get the whole clips. I will just show you a bit more on this clip, and then I will jump to the relevant bits for the pressure of time. And this patient has Horner syndrome. Now, first thing you see, the hand is puffy, and there's been no movement for a period of time, so there's no flexion crease. And what, apart from being able to talk, you have to demonstrate to the examiner how you can interact with the patient comfortably, how you can cradle the arm. And in this case, she had no movement to demonstrate. So it's a matter of laboring the point and also showing that you know what you're looking for. You still have to show the system where I started from proximal to distal. But it became clear very quickly that she had no muscle contraction at all. So in this situation, then it looks really tedious if you want to demonstrate FPL, FDS, FDEP individually, because then it demonstrates that you haven't developed that higher order thinking, because you should recognize by now there is no movement. You will notice that I always start with motor function first, because as a reconstructive surgeon, motor reconstruction is higher in terms of the priority of reconstruction. The sensory reconstruction comes later. Sensory testing is not as reliable as the motor. So if you want to start off with sensory, a word of caution that you may be misled to think that it's of certain pattern. It may actually color your examination of the motor function later. So I would suggest check the motor function first of all, because you can demonstrate a lot more by the MRC grading, by the way that you handle the limb, then only do the sensory testing. So the next pattern is when you have a poor shoulder, good hand. So what is it going to be? It's an upper roots brachial plexus palsy. This one I think is worthwhile going through together, because it's likely to come out in examination, because it's a fairly common pattern. First observation is that there is generalized wasting around the left shoulder girdle muscles compared to the right side. I always start with trapezius, because spinal accessory nerve is a donor nerve in my reconstructive armamentarian, but it demonstrates higher order thinking. That is like if you're aiming for 7 or 8, then you can discuss that. But that's just my routine. I always start from the top there. But you can see the evidence of wasting here. And here I'm examining for latissimus dorsi. And here, the patient clearly does not have the ability to elevate the arm anymore. So by supporting the arm, what I'm trying to demonstrate here is scapular winging, weakness of the serratus anterior. And here I'm palpating for the pectoralis major. Take note of how I interact with the patient, and not only did I ask the patient to push, to pull, to resist, my other hand is actually on the muscle that I am testing. So neurological examination is very interactive and it has to be cooperative. So if the patient does not wish to be examined, then your examination findings are not reliable. Now this is the key. So the patient has no bicep at all. You have to demonstrate you understand MRC by elevating, by eliminating gravity. So instead of telling the examiner, oh, I know what MRC is 0, 1, 2, 3, 4, 5, or 1, 2, 3, 4, 5 are, better still, you demonstrate how you can apply